No noise. So welcome everybody. Today is the our second class, and it is on the capture management. Anand is, I think, is going to present this one, and it is a very interesting topic. A lot of time we are not knowing what exactly where to start the capture management system, and inadvertently, if we are doing it, sometimes it bring a lot of troubleshooting issues. So over to Anand, and you are having 15 to 20 minutes. So you can start. Yeah.
Thank you so much for the opportunity, sir.
Yeah.
So myself Anand from Medtronic. So I'm going to take care of capture management topic today. So let's go with the presentation. Yeah. So before stepping into the topic, I'll just tell the overview. So this capture management, what is the clinical need for that? So in older days, in the generation pacemaker, we had SSIR pacemaker and SSI pacemaker. So during that time, so we don't have any these fancy algorithms and all. So the device will pace and device will sense. So and it will give like it will work like a demand mode. So what is the perfect need for this capture management? So I'll show it into the upcoming slides. So one second. So here is one of the like good example for the threshold trend. So we are going to discuss about ventricle capture management. So here you can able to see the acute to chronic threshold changes in this trend. So we can assume that it's an like 2-year trend. So you can able to see this above this line. One second. So whatever I'm showing here, this is a fixed output. So we kept output of 2.5 volt, and this is a non-capturement, non-capture like management. It's not an algorithm in this device. So you can able to see here. So in over the time, the threshold is getting increased day by day and month by end, year, like week by week. And at some point of time, it is crossing the fixed output. So obviously we will know this part of time the patient is going to miss the capture. So ultimately, we know pacemaker is one of the life-saving device. The patient is missing the beat means then it's the device is not satisfying the need. So again, it is coming back to the the thing. But anyway, we will come to know in this part the patient will get any symptoms if the patient is completely dependent means. Then the people worked out how to like overcome that. So then they came up with a solution like that's called capture management. So that's what we are going to see here. So what exactly this capture management is going to do? So the capture management it's going to be continuously evaluate the rhythm. So and whenever the rhythm gets like non-captured or something means it will change the output. So how it is going to change the output? That means it should find out the threshold. So then we should know what is threshold and what is capture. So let me show here. So capture is nothing. The capture is means whatever the like electrical stimulus given by the pacemaker. After that, there should be a depolarization in the heart. So that we will in our term that we will call as a capture. So that is an effective capture. So then what is capture threshold? The capture threshold in simple terms, the minimum amount of energy like which is required to like depolarize the heart myocardium, that we will call as capture threshold. So then additionally we will see about like safety margin and all these things in the like future slides. So then now we will see what are the things which will affect the capture threshold. So a lot of things will affect. I'll show you one by one. So yeah, here you can able to see here the patient conditions. Mainly the patient condition will affect the capture threshold, such as medication. So some patient may take different medications. It will like abruptly like increase the thresholds and decrease thresholds, and electrolyte imbalance and ischemia. Yeah, obviously even in implant also you can able to see the like if it is in the scar area, definitely the threshold will be in the higher state. So that is another thing. And lead impedance changes. Obviously everything is going to work in the Ohm's law pattern. So definitely if there is a one lead impedance change also, then it will obviously affect the current flow. So that is another thing. So yeah, obviously we've seen like this is a solution is capture management. And now I'll step into how capture management is going to work. So, and this is an advantages like what it will happen if you use capture management. So there will be a reduced battery because you are going to optimize the like current drain like based on your threshold. That means you are not going to constantly give the current. So most of the patient will not require much current also. They will be in the very lower side. So for those kind of patient, it will be very helpful. So it is going to reduce the current drain like in appropriately. So and because of this, you don't want big batteries also. You can compromise on your battery size, and it is obviously going to help your entire pacemaker. It will be in very little size. So that is a downside of devices here. And obviously acute to chronic threshold changes are all these things it will monitor and it will adjust the output accordingly. So, and obviously the ultimate goal of the pacemaker, it will not like miss the beat anymore. So it will constantly monitor and it will give the like whatever need it will satisfy. And it's very, to keep it simple in a nutshell, it's an automatic algorithm. Just turn it on, like be restless, like you can be like this device will take care of everything. So this is in single word.
Is automatically it is checking all the time.
Yes.
Time to time. Means it is
It's a
having
time to time.
It will follow and then accordingly the battery, the thresholds, not the, on the threshold it is going to give the particular pulse.
Correct, sir. So this is the, I mean, to put into all nutshell, this is the entire thing, how this capture management is going to work. So any algorithm, if it is it wanted to work in the device means that there should be a stable rhythm. So first that is, and second thing is it will perform the pacing threshold search. So this is a little bit different how we are doing in the manual layer. So the third thing is how it is going to determine whether the capture is there or not. So it's a simple question. We know we will connect ECG and we will see in ECG we can able to see. So that is a pace repeat or sense repeat. But device how it is going to know. So there is an interesting concept called evoked response. This evoked response, what it will do. So after pacing spike, you can able to device can able to see the depolarization in EGM, the electrograms. So there will be two different electrograms. One for the pacing spike. After that, there is no depolarization. Means according to device, it is an like non-captured bit. And after the pacing spike, if it is a negative, that depolarization will be there. So that will be a captured bit accordingly. Even though there will be some disadvantages also there in the evoked response. So based on the implanting things. So let us see in the future. So and finally, after doing this this test, then it will determine the threshold. So what is the threshold? Then after that, it will do the strength duration curve. So everyone knows this Rio base and Chronaxi curve. Then after that, it will plot the like final output. So let me show that. So anyone can able to tell here what's exactly happening here in the team?
Yeah. What is happening? What is happening here? Oversensing, undersensing, color change. Oversensing and undersensing. But the answer is what is happening here? Loss of capture कैसे कर सकते हो? How you can say there is loss of capture?
It's oversensing is absence.
But it is really is a loss of capture.
I mean, to represent here, the pacing spikes may not be like visible here. So this is one of the classic example for loss of capture. So what ideally there is no
loss of capture, but one thing you have to remember:
the pacing spike.
The pacing spike is unless you are not able to show the pacing spike in unipolar, you will not be able to say. Bipolar, it is very difficult to see. But even in this one, we can see a lot of noise is there.
Correct, sir.
And there is a P wave is there. After that, so if I have to give an interpretation, I will say there is the sensing,
oversensing,
and it is not pacing it.
Pacing it correctly.
That may be a possibility, though for the class point of view, maybe the capture.
It's a loss of capture. So, like, I mean, what we can able to understand here. So, even though we implanted the device, but the device, there is no benefit from the implanted device because the patient will again get symptom whatever these things. So, yeah. So, as I said, the first step is to check the stable rhythm. So here you can able to say, so this is how the device is going to check the stable rhythm. So it should, I mean, it should not more than 2 beat. It should not like go out of this in these ranges. So if all these criteria are satisfied, means the device will tell the patient it has stable rhythm and it is the good time to check the capture management algorithm.
So not more than 2 out of the 8 VV interval are faster than 100, 95, 90.
90.
These are the programmable.
Yes, sir. These are all the, I mean, the things each device should be. It's a device will check, sir. It's an algorithm running idea. So before stepping into the algorithm, device will check for the stable rhythm. So in the last 8 of that 8 beats, so not more than 2 beats, it should not cross 85 beats per minute. And all these things, three things should like get green tick.
Give the time to make it understand. First is stable rhythm, it has to check.
Correct, sir.
Okay. So not more than 2 out of 8 VV interval are faster than 100, 95, 90.
Correct,
what
sir.
does that mean?
So
if it is more than this, you are saying it is stable or unstable.
If any 2 of the beats, if it is violating these 3 things, the rhythm is unstable.
100 beat, 95, 90.
Yes, sir. It's based on the programming, sir. For example, if you are programming the patient 125 beat, 125 beat means it should not cross 90. Okay. In that manner, they are saying.
It is example.
It's an example how it is going to vary. Okay. So by using this, if you are programming the rate, you can able to analyze. So what will be the rate for capture management? So Yeah. So the second thing will be the sensor rate. It should be below the ADL rate. So everyone knows the Medtronic has the activity. If the patient is in rate response mode, there will be a ADL rate. So activities of daily living rate. So the sensor rate obviously it should be in the like less than ADL rate. So the pre-programmed ADL rate will be 95 beats per minute. So and the third thing is the patient is in dual chamber mode. At least one out of the 8 intervals should have valid ASVS or ASVP in the 4 following pattern. So to avoid the oversensing or undersensing things.
At least 1 out of 8 has a very clear interval. Okay.
Correct. So during the and one more thing is during this capture management, this following like special features will not be enabled. So rate of response will not be enabled, and mode switch and battery measurements, atrial preference spacing, and sleep function. So these things will not run in the background. So anytime. So usually the ventricle this capture management will happen in like midnight, 1 o'clock, or anytime rest of the time during the search. So the second thing is the step number 2, perform pacing threshold search. So here is an interesting thing. We can able to see how the device is going to check. So before like checking threshold search, what device will do? It will give 3 support cycles. So these support cycles, why they are giving means, so for example, if we can't able to give the directly test pulse to the device, so we don't know the time the patient may have PVC or undersensing may happen. So this will compromise the capture complaint, whether it's a true capture or not capture. So we can't able to analyze. So to like check the threshold, the device will set the platform first. So here it is giving 3 support cycles. This support cycle will be in the programmed amplitude on pulse width. So after that, what it will happen? It will give one test pulse. That is our threshold search. So it is going to give a minimum output or maximum output. So according to device things, it will give. So after that, we don't know whether it is going to capture or not. To overcome that, device will give backup pulse at the programmed amplitude and 1 pulse width. So we will usually program 0.4, but the device will give a pulse width of 1 pulse width. This will happen within 110 milliseconds. So whether the this test bit even if it is non-captured also, this backup pulse will give capture the patient. If it is captured, this test bit capture means this backup pace, it will be in the refractory period. It will not like induce anything.
But 2 pulse will be coming always.
Two spike will be there, definitely.
2 spikes will be there.
Yes, sir.
It is a marker that it is a capture.
It's a capture management.
So how are you going to do the safety this one?
Sir?
Safety pacing is happening from the banking unit point of view.
That ventricle safety, it's a kind of same window, but the working method alone, it will be in the capture management. So this is a cycle 1. This is cycle 2. The same thing will repeat for another cycle. Again, the same thing will repeat for 3 cycles. So to ensure the 3 times captures. So this is the threshold search. So to determine this, any of the 2 sets will come as capture. So 1 set we can compromise as non-capture also. So out of 3, 2 should be in the capture side. So to determine the threshold. So this is one of the classic ECG example. So I'll show you, sir. So you can able to see here 2 pacing spikes, sir. So here you can see this first one is test bit is not captured. So the device given backup pace and it is captured. So given the backup pace. Here you can able to see, sir, this is the test pace itself captured. So this backup pace is falling in the refractory. So this as 3 support events is there. So whatever we seen in the same thing they given, sir. So you can able to see this 110 milliseconds backup pace and test pace. So how this is going to be determined means, if it is in the dual chamber device means it will take the whatever the average AV delay minus 15 milliseconds. So that will take here, sir. In single chamber it is no much complications. So determine threshold using evoked response. So as I already discussed, so based on myocardial response, the device will classify whether it's a capture or non-loss of capture. So accordingly, device will function it. So here the one disadvantage is, so in some if the lead tissue interface is not great, means you will not get much evoked response. So on those scenarios, device may classify even the captured beat as non-captured beat. So that times sometimes the device, the older device may not. Run in a very good manner, but nowadays the device, newer generation devices are very much sensitive, so it can able to get even the very minute myocardial that response is also can able to pick up. So that is one of the good changes.
Response, how it is device is reading response?
Sir, it's purely based on the EGM deflection, sir. EGM deflection. It's purely based on EGM deflection, sir.
So when it is when pulse is going through the cathode. Again, something is going to be recorded by the anode, you mean to say?
Yeah, correct, sir. So after, if there is no capture means, then that there will not be any current flow to the anode in the tissue. So you can't able to, I mean, if anything goes through the tissue, there will be a slight delay because that is not the actual pattern. If anything goes through the medium of like other like direct thing means there will be a quick thing. You will not see any deflection there. It will be a straight line. If anything comes straight line after the pacing spike, that will be like non-captured bit. So after pacing spike, if it is a truly captured bit, then you will get the delay. Then you will see the negative deflection in the EGM. So that we will see in the EGM also after pacing. So that we will determine as a capture. Yeah, as I discussed already, these are the things can affected by affect the evoked response. So one is lead tissue interface, and is lead polarization, and tip to ring spacing, and lead tip design, and like other factors. So I'll advance it to the other slide. Yeah, so this is also I already discussed. So out of these three, any two should come as capture. So then only it will determine as above threshold. If any two comes as loss of capture, then it will put this as below threshold. So conditions. Yeah. So we are in the almost final step. So here the strength duration curve. So everyone, we know the strength duration curve. Here we are going to see how it is going to plot. So yeah. So here you can able to see these three green dots. So this is above threshold. This is also above threshold. This is also above threshold. So this red one is loss of capture. So we know after that. So if anything loss of capture, the near capture bit is we will call as capture. So this one, according to us, this is the capture threshold for this device. We will keep safety margin here. So 3 volt. Then again, this is for this amplitude test. So parallelly device will do pulse width test also. So pulse width test, how it is going to happen means whatever the threshold into 2. If you put means it will the same thing happen in the pulse width test. So here we reduce the amplitude. Here we are going to like oppositely reduce the pulse width. So till loss of capture. So now we found out the pulse width loss of capture also, and pulse amplitude loss of capture also. If you draw a curve in this both region means we will get the like strength duration curve. So based on this only, the final recommended setting accordingly, whatever the points intersecting here, this will be the final recommended setting. So device will program this based on the strength duration curve. Yeah, and ultimately what will happen? High threshold warning. So what it will here, if any output for Medtronic devices, any output it is goes more 2.5 volt, the device automatically will switch to 5 volt and pulse width of 1 milliseconds to ensure that capture. So this is one. So whenever we are interrogating again, we should re-verify the things and we should optimize it, sir. Otherwise, it will be in the 5 at 1 only. So this will impact the battery. So that's it, sir. So 1 second, sir. I will just wanted to show one more slide. It is hidden here. Yeah, this is the one.
So how you activate it?
That's I'm going to show you now, sir. So you can able to see here in after clicking in Medtronic devices, after clicking the parameter screen, you can able to get both atrial capture management and ventricle capture management here. So here both will be there, sir. So here we see in ventricle. So here it should be in adaptive mode. So if you click here, 3 options will be there. If you put it to off, device will not optimize anything. It will work on the programmed output. Here the second thing is monitor only. So the interesting thing here is device will not change any output, sir. It will always monitor and it will do the threshold search and it will plot and even it will give you in the graph also. You can able to see how the entire threshold goes ups and comes. But even if the patient in loss of capture also, device will not do anything. It will just monitor. Okay. So just for our diagnostic purpose and adaptive. So if you put into adaptive, then just device will take care of everything, sir. It will check and it will optimize the output, everything it will do. So adaptive mode we need to on it, sir. So and capture management, sir.
It is central, it is auto capture.
It's auto capture. Here it's capture management.
Yours is what? Auto. Yours is auto. So,
Pace safe.
Ours is auto, sir.
Only auto.
Only auto.
उसका auto capture and इनका capture. Okay. Are you getting this point? उनका क्या है? Biometrics क्या?
Biometric is also auto, sir.
Auto.
So biometric and custom, so both will come. But if you click on the, so there is no separate option. So if you click on the amplitude, so there will be a box. In that box, so 0.1 to 7.5 you will see. Above the 0.1, so you will see auto. If you select that, so device activates the application.
So, and additionally here, sir, you can able to see the capture adaptive. After putting adaptive, here you can put amplitude margin. So here what will happen, sir, if the threshold is going to 1 volt means here you can fix it. It's a two times you want higher the threshold, or 3 times you can able to click here. And minimum adapted amplitude also you can keep. So let's take assume your threshold is 0.25. So if you click 2x means then it will give only like 0.5 output. So you can't able to program 0.5 output also. Sir, this is going to be a very
Come again.
so this amplitude margin I told. So whatever the
2 times, 3 times
we can program it, sir. So and here if you are going with a 2-time concept, then there will be a disadvantage. So let's assume your threshold is 0.5. So if you are giving 2 times, so 0.5 into 2 we will get like close to 1 volt only. So you can't able to program 1 volt also in ventricle, so that will be very low. So to cover up that, we will come up with we came up with minimum amplitude, minimum adapted amplitude. So even the threshold, even the 2-time margin, it is going to come at 1 volt also. If you put here are 2 or 1.5, the device will not go below 1.5. So that is a good thing, sir, here. And if you then you can able to program here when it is going to happen. So ventricle, it will be always day at rest. If you don't want that, you can program time, which time it should happen, everything you can say program it. Day at rest means whenever the sensor will be in the rest, it should be obviously it will be in the night time, so it will check, sir.
Day for rest means sensor job.
Sensor should be in the rest stage. The patient should not do any activity. So, and this another one thing is acute phase days remaining. So some people will say after implanting Medtronic device, they will see after 1 month threshold, since it's 0.5 only, but device still it is in the 3.5. It is not adapting, even the automatic adapt turned on. So there the possible reasons are the acute phase days remaining here should be turned on. So what will happen, sir? After implanting, we will keep 120 days as the acute period. So during that acute period, we know the threshold may vary, like it will go up and down. So that time we don't want to adapt the device into very lower outputs. So we will keep 120 days. Till that 120 days, the device will be in 3.5 volt output only. So after that 3 months, then automatically device will get optimized according to the threshold. So if you don't want means we can put it into 0 or off. Then device will the next day itself, device will start adapting to the minimum amounts of. So for the PG changes, we will have.
Ideally, it should be off in the initial part.
Ideally, it should be on, sir. At least for 60 days, we should on 2 months. We don't know whether lead will dislodge sometime. Micro dislodgements will be there. So to cover up that. So we will put this off into PG change patients. Anyway, we know the lead is matured. So that time we will put it up. We don't want anything. So ideally, that is correct, sir. So this is all about things, sir.
How much sensitivity is that it is not going to falsely read that evoked responses? There is any
still I didn't see anything, sir. What device will say, sir, it will go the next level. It will say threshold search failure. So I seen like that. It will not give the output also, and it will increase the output. It will tell like that, but never seen it falsely found out something as threshold. I mean, regular response like that. So it will go to the next level and it will say capture management failed. You should do another manual. So like that, it will say I seen like that. So here you can able to see the trends also, as I discussed, and like last 18 weeks of points. I mean the threshold things you can see. So according to that, here you can able to see everything, sir. The date by date you can able to see. So everything that how it is determined. Everything it will come into by, sir. Just 1 point you can able to see everything. So if any high threshold went means, so it will put here when it went high threshold. So on last 15 days details, and here when last measurement happened, what time, everything it will be here.
So it should be ideally on in all.
It should be ideally on.
Monitor should be there.
Correct, sir. So in the trend, if you see, there will be some gaps. So these gaps determines the patient at that time capture management not like successfully did the test. So these are the gaps for those things. And I just wanted to add one more point, sir. So here I never here you can able to see the time itself will come during the threshold search. So I mean, for a couple of years I had this doubt, why the hell we want time here? We don't want time, just date enough, like that I was filled. So recently I encountered with one patient, sir. It's an LV capture management. So the patient was on 24-hour Holter monitoring. So the patient had during like around 3 o'clock, the patient had LV capture management running in the background. So the patient had a few non-captured beats and few purely LV paced beat and pure no paced beat, by V paced beat. It was in the mixer. So then one consultant found out in the this one a Holter, then they are like so something happening with device and like some malfunction is happening. Even for us also it looks very crazy. We never seen like that. Then we found out that how finally we did in Holter, we didn't get the entire data. If I get the raw data, I will easily find out. So only that strip, based on that strip, we can't able to find out anything. Then what we did simply, we found out the same date in Medtronic device. You can able to see last 15 days when it threshold capture done and what time it is done. We seen that we compared with that date and time, this Holter, the strip date and time, it both exactly got matched. Then we found out it's an LA capture management. So on that way, this time will be very useful, sir, for to find out these kind of things. So this is all about capture management, sir.
Thank you, Anand.
Thank you so much, sir, for the opportunity.
Yeah. So next, I think Madhu. So Madhu will be speaking on
Sleep apnea, AAP Scan.
Yeah. So this is also very important topic. What I find is not too much discussed. We hear a lot that for the sleep apnea patient, we are having some algorithm which will help in the pacing. So Madhukar Reddy will be telling. He is from Boston, and he will be telling about that sleep apnea protocol in the pacemaker, AP scan. Huh? Yeah. Thank you.
Good morning, all. So, thank you very much, sir, for the opportunity.
You can use this one up down करने के लिए. This one. And इसका तो I don't think one नहीं करता.
I will use this, sir. This is very easy.
ये easy रहता है. इससे easy रहता. You will be more relaxed. You can directly see there.
Okay.
If you want to keep like this one. बैठ के कर लो आराम से.
I am comfortable.
Oh my God.
So, you can, sir.
इनका ये गड़बड़ है.
Thank you very much, sir, for the opportunity. So, myself, I am Madhukar Deva from Boston Scientific. So, today I am going to discuss about the AP scan, which is a feature of Boston Scientific. So, unique feature in the industry. So, sleep apnea. So, this is sleep apnea is a potential serious sleep disorder in which the breathing repeatedly stops and starts. So if you snore loudly, that means like you have some kind of apnea concern. So and feel tired even after a full night's sleep. So you may have a sleep apnea. So there is a high possibility. So you may feel that I am completely slept well yesterday night, and because of this, so if you feel tired when you wake up, so there is a high possibility that you had a sleep apnea issue. So there are main two types of sleep apneas. So correct me if I am wrong, sir, anywhere. So there are two variety of sleep apnea that we will found. So one is the obstructive sleep apnea and the central sleep apnea. So the obstructive sleep apnea is the most common sleep apnea. So the throat muscles relax and blocks the flow of the air into the lungs. So that is the concern. One way of the sleep.
You can escape this one because clinically I will let around 4 minutes.
Sure, sir.
Yeah.
So the symptoms of the sleep apnea is the loud snoring. So episodes of which you stop breathing during the sleep, which would be reported by another person. So gasping air during the sleep, awakening with a dry mouth. So morning headache. So irritability is also a cause of this. So I will just go through this, sir. So allow me some time. So we will have better idea what exactly I am talking now. What happens if you stop breathing for 10 seconds during the night? So there is a high possibility the heart rate will increase, the cardiovascular risk will increase. So the oxygen which carries to the brain, so it will be compromised. If that event happens 30 times in an hour, if you take and an average 7 hours if you are going to sleep, so total around 200 or 210 times that you are going to have the obstruction of the sleep apnea disorder that you are going to have, you may have. So the serious concern or the consequences of the sleep apnea is, so it will increase the AF burden or the risk by 4 times. So ventricular arrhythmias by 3 times, so sudden cardiac death about 3 times, and heart failure mortality into 2 times, heart failure morbidity is 2 times. So these are the consequences that may occur if you have a sleep apnea. So, in sleep apnea is one of the most common comorbidities in patients with cardiovascular diseases. So, sleep apnea is about 60%, up to 60% prevalence in CRM population. That means who has the device. So, the patients are undiagnosed. About 80% in heart failure patient population and 60% is in ICD and pacemaker population. So all these numbers we got it from the clinical studies. So there is a if you diagnose or if you are able to screen the sleep apnea in a patient, so there is a possibility you can confirm with the patient and you can treat as per the European Society of Cardiology. So treatment options are available for the sleep apnea. So how Boston Scientific device will recognize this? So with the trend, with the sensor, whatever the Boston Scientific has. So we have 2 sensors in our devices, in all the devices. One is the accelerometer and the other one is the minute ventilation sensor. So with minute ventilation sensor, all these calculations will be done by the device. So the trend use the transthoracic impedance measurement to monitor the breathing patterns of a patient. The pulse generator consider respiratory disturbance event, how the device will takes care of it. So if you see, so 26% of the normal breath. Example, so if you see here, now, if you see here, so there is a time, this is about 10-second pass, and if the amplitude of this is reduced by 26%, so then the device is going to calculate that is as one event.
Okay. Means any servo breathing is happening, it will take.
It will take, sir. It will take.
Means the
So if
impedance, na?
based on the transthoracic impedance, so the transthoracic impedance it measures from the RV coil and the cap.
Okay.
Or if there is no device or ICD device, so it checks with the RV lead impedance tip. From there, so it checks the measurement. So if the breathing pattern, if the device finds if there is a gap of 10 second gap by reducing the amplitude of 26%, then the device is going to plot that as one event in this particular time. So like that, it keeps on checks. So if those kind of events are 10, 25, so it plots. So how it plots, I will show you. So this is a typical patient's 1 year trend. If you see, so this is zero here, zero events, 10 events, 20 events, 0 events, 5 events, 10 events, 20 events, and 30 events. So for the device, if it is the, so I will come back to this slide. So if the events in 1 hour from 0 to 5, then it says so there are no sleep apnea disorder for this patient.
Less than 5.
Less than 5. If it is from 5 to 15, so there is a possibility that this patient may have a sleep apnea. That is the mild sleep apnea disorder that device can find it out. If it is in between 15 to 30, so we can consider it's a moderate sleep apnea disorder this patient may have. If it is beyond 30, that means this patient is at this patient is at a risk of the sleep apnea. If the numbers of these events are per 1 hour. If the 1 hour, if the device is able to say get more than 30 events, severe sleep apnea this patient may have. So this trend is available with Boston Scientific device about 1 year. 1 year trend we can have, so you can see how frequently so this is changing. If something severe means like this is the 30 that we will is a landmark for the severe sleep apnea. So from here something goes above, that means this patient is going to have a severe sleep
30
apnea.
events per hour. Okay.
30 events per hour. So you can go back and check by clicking that month 3, so up to 1 year, so we can see.
It is in the events which will become.
Yes, sir. It's in the event. So if you go to the trends, so we can get the data of this. So the diagnostics features, anyway, this is related to you, and so there is a possibility. So once you, so recently we encountered with one patient at Gujarat. So this patient showed the trend of more than 30 events in a hour, and this patient came for follow, and patient said like, I'm absolutely fine. So when we observe the trend, so this is what is going to happen. So we requested the physician to check with the check for the screening. So the patient put the screening tool, and the patient is diagnosed with sleep apnea, and the patient is having CPAP now. So the screening, diagnosis, these are very two important things. So how normally, so this is the diagnosis of the sleep apnea. So how the people diagnose in terms of, so there are a variety of machinery which is available. So these are the two variety of things. So they will identify this. So polygraphy and polysomnography, there are two varieties of this. So these events will be covered like apnea, hypapnea, obstructive, central. So all these things will be covered by these instruments, and they will give the proper information. And these are the guidelines, these are the therapeutic things. So when it comes to Boston Scientific, so the programming part is here. So if you go to the patient information in the programmer, so there is one option which is the sleep schedule. So you can start the sleep schedule. So the time whatever the patient is going to have a sleep, so accordingly, so you can set these timers. So the timing can be as per the geographical thing. So as per the patient need. Sometimes if the patient is having the night duty work, so you can switch this back to daytime where the patient is having a sleep in the daytime.
So basically, it is for diagnosing.
It is only for diagnostics.
Not it is going to
Yeah,
be
no,
therapy.
no. There is no treatment from Boston Scientific.
AAP scan. What does AP means?
Apnea.
Acha,
Apnea scan.
Apnea. Okay. So it is only with Boston or any other?
This is
company?
only with Boston because
Yeah.
we are no.
No, sir. In like any other.
Because sir, so we are the only company, and no other company is going to come in future, because so we are the only company to have two sensors in our device, which is minute ventilation sensor. In fact, Medtronic in the previous generation, N-Pulse is one of the brand. In N-Pulse, so they used, instead of the accelerometer, they used only this. In the device, even this feature is available. It was not marketed well at the time.
Good.
Thank you, sir. Thank
So this is a unique. So let me summarize it. So we read two topics. One is capture management. So capture management is an important topic. We are having little knowledge. Capture on means it will be capturing, and we have been taught one thing. It's a two system working in everybody. We know something and we try to extrapolate that we are knowing it. But frankly speaking, even I am in the practice for last almost 16 years with the pacemaker. But a lot of modes, we know that probably we are knowing, but in depth, how it works, we don't know. It is our tech guys who are knowing in depth, and we are taking their assistance so that they can give a better review how the system works. You should know the strength and the weaknesses. If you are knowing the strength, it's okay. But if you are not knowing the weaknesses, you can lose the patient, you can complicate the case. Now, with this word, I will move to the today's one more topic. This is a question which we will be always asking from the house, because it is a device class. So there will be always a question. I have kept only one question, not more. And this is a very pertinent question. So last time we discussed regarding a case. This is a case number 2. So patient come with a palpitation on and off. The diagnosis is intermittent AV block. Implanted DDDR pacemaker 12 days back. Percentage of pacing atrium 0, ventricle 2%. The sensing P wave is 2.1, R wave is 7.8, threshold lower than 1.4 for both A and B. Okay, this is the information. The main complaint palpitation every day with no specific timing for the coupling minutes. Admit to the hospital, observed on monitor, and we found that unnecessarily pacing faster than the lower rate with and without AV synchrony. And these are the things. Any comment?
I know the answer.
Huh?
I know the answer.
So the person who is knowing the answer, they should not. But I want from the house. 1 minute.
It's like PMT.
PMT. Okay. For PMT, what are the things required? For PMT, pacemaker mediated tachycardia, what are the 2 things required? Sure. Yeah, Madhu.
Sanjay, I think Sanjay or Srikant, I expected answer.
Tell me, what is happening?
So, sir, it's a typical Boston Scientific strip. So, in Boston Scientific, there is no specific time for the capture management or the auto capture. So, every 21 hours, our device will check the thresholds. So, during that time, so because this patient is a non-dependent, and when the thresholds are activated, the rate is slightly increased to 90 or 100 as required by the device. So, during that time, the patient is feeling the palpitation. Other times, so there is no palpitation stimulation.
So why it is happening so long?
So our device will start the thresholds from 3.5 till the loss of touch each and every time.
So this was also a learning for me. I was also not knowing this. Every device having a different way of measurement. So the important part is, so you can see here it is started and ending and anywhere means in the electrophysiology, or we can say in arrhythmia, the 2 part is very important to see how it is started and how it ends. If you are not able to capture the starting part, try to capture the ending part. You can see the ending part so nicely. It means normal rhythm is going and in between the pacing is coming. So what are the possibilities? Yeah, it is totally device related. Device is doing something or it is misinterpreting. Either of the things, these things. So middle part, everything is fine. Pacing is going on. But why it should pace when its own original rate is normal? So it is trying to check something. What Madhukar was saying, it was correct. So terminal event has happened. It has got that what is the threshold, and after that it is totally silent. So this is the thing, ventricular interval variation. 0, 11, 21. Can you just tell me what is it? According to you?
So correct me if I am wrong. So the interval variation in the ventricular for this patient, so 0 to 10% is about 422 beats. If the variation of the ventricular interval from 11 to 20% is about 257. Variation from 21 to 30% is 900. So beyond 30%, so there are no, beyond 30% is 900 beats which were varying in the ventricular interval variation. That is diagnosed by the device from the last session till today.
So in this whole, this counter water, which has been captured, the most important information, he has told that is a auto capture, or you can say capture management. But what most important thing is, what are the things here you are getting? A pace, V sense around 98%. Is it okay? A sense, V sense 98, A sense, V pace is 2%. Is it clear? So answer is normal function, malfunction. Normal function. So it is a normal function, not neither over nor under. No lead insulation, because sometimes that initial, if you can see the strip, here some noise is coming and people will be thinking it is a noise problem, but it's not a noise issues. You have to show under sensing, over sensing. So there is no and lead insulation issue. What he was saying, every 8 to 20 on daily, it will be starting 3.5, every down set, no, and until 0.1 loss of pressure, 2 out of this one. So it was a Boston device, and the important lesson is auto capture where to activate. One part he has told where activation should not be done. This is the lesson for everybody. Auto capture should not, means capture management, auto or capture. It should not be activated if the patient is having atrial fibrillation or the percentage of pacing is less than 25%. It is a wastage of the resource. It is not going to work out. So patient, if it is a pacemaker dependent, where the threshold can go up initial part, what is the, we have put the lead, you are not knowing whether the lead will be stable or not, you are still having a doubt, activate it. So it will help, because you have kept at 3.5, it may be at 5, it may capture, but if you have not kept it, you have lost the patient. So this is the safety system that you can activate for the patient, and wherever the thresholds are high, these are the patient where you have to activate. So intermittent pacing is not an indication for auto capture. So never activate auto capture. See the ventricular pacing, how much it is happening. If it is less than 25, leave it. Atrial fibrillation, don't do it. Unnecessarily waste it. Because there is I think Anand was saying, the rhythm should be regular. Unnecessarily, when the rhythm is still struggling, what is the fun of putting the auto capture in that one? It will misinterpret the things and make the things more complex for you. So rhythm should be regular, capture should be at least 25% plus, and you are still having a doubt, probably the threshold are unstable, activate it. It will help the patient. Okay. So this is the last lesson for today. So we will meet next time. So always look start and end part, and wherever pacing is happening, patient is complaining of palpitation because he is doing fine. All of a sudden, the heart rate is going, so he is feeling palpitation. So this was the reason. And whenever the question is going to be framed, the typical this normal pulse, and after that capture. So you will say malfunction is happening. Why? What Anand was saying, that LV lead threshold is being checked, and people are thinking something wrong. Okay. Next time again we will be meeting for next questions. Okay. Thank you so much. Yeah.